Hello everyone, my name is Tadesse Girma. I am from Ethiopia. I'm a general surgeon working in Jimma University Medical Center, teaching and referral hospital in southwest part of Ethiopia. My presentation is on a quality improvement project conducted to reduce elective surgical cancellation rate in our hospital. So this is the abstract of my presentation. Just I will mention few pointers, otherwise I will go through the entire document. Cancellation of elective surgeries is a major problem, especially in low and middle income countries, and the prevalence in our hospital was around 31.5. So the objective of this research project was to reduce elective surgical cancellation rate in Jimma University Medical Center. So we used a model for improvement using PDSA cycle, Plan, Do, Study, Act cycle, and the result was presented during run charts. I will show you the result on the final part of my presentation. So generally, the operation room is a highly expensive area of the hospital. It requires substantial capital outlay and ongoing investment. It requires extensive resource for efficient workflow in the operation theater. So efficient workflow in the operation theater helps us to enhance patient satisfaction, create safe OR environment, and to maintain judicious use of resources in the hospital. So background of my presentation: unexpected cancellation is one of the most disruptive events in the operation theater, with a range from available literatures according to a systematic review conducted by Adunya, 0.3 to 44%. Cancellation on the day of surgery has a negative impact to patients, families, and the staffs as well. It has both psychological and financial consequences. So cancellation rates vary from hospital to hospital and more prevalent in sub-Saharan countries. In Ethiopia, cancellation rate ranges from 12.8 to 30%, according to some available literatures. Literatures are not abundant in our country. So in the case of Jimma University, we have to conduct a pilot study prior to the starting of this project, and it was around 31.5%. So we conducted some literature reviews to know what are the available factors and to identify the gaps that should be addressed for our intervention. So cancellation of surgery on the intended day affects OR efficiency, reduce OR time utilization, and wastes resources. Cancellation is the commonest cause of reducing OR efficiency. So measure of OR efficiency is controversial. However, cancellation rate less than 5% considered efficient in some hospitals, according to some literatures, and whereas others measure OR efficiency using table output per day per table. The incidence of OR cancellation vary based on hospital setting, culture, and economic status. It is much lower in high-income countries, ranging from 12% to 40%, whereas in low and middle-income countries, according to some literature, this may raise up to 73%, but majority are less than 5 or 50%. So majority of cancellations are avoidable, while only 20% are unavoidable. The causes of cancellation can be patient-related or facility-related. According to a cohort study conducted in UK, 33% of patients were cancelled due to change in medical condition, while 31% were due to lack of bed. And a study from Middle East shows 67% of cases were cancelled due to patient conditions. And in our country, I found one study which shows 35% of cancellations were due to absence of surgeon, which is very unusual in other literatures. Even though absence of surgeons are mentioned, but this was much higher. So in Jimma University Medical Center, majority of cancellations were due to inadequate time and patient medical conditions. So as you see, there are different factors in different settings. So it is essential hospitals analyze the root cause of cancellations at their own hospital to improve efficiency and use different approach to solve this problem. For us, we use model for improvement, but other innovations or other models like Lean or Sigma may work. So the aim of this study was to reduce surgical cancellation rate in Jimma University Medical Center from 31.5 to 10% in 10 months. So the objective was to reduce surgical cancellation rate, to improve early initiation of first incision time, to increase OR efficiency. So these were the research questions. Using model for improvement and using our change ideas, will it improve our efficiency is the research question. So Jimma University Medical Center is a teaching and referral hospital serving a catchment population of 20 million in southwest Ethiopia. The hospital offers a comprehensive range of emergency and elective surgical procedures. In this, the study design we used was model for improvement using PDSA plan to study act cycle. The study was conducted from September 2022 to June 2023. So we conducted a 3-month pilot study. A total of 689 patients were scheduled and only 469 patients were operated. The remaining 220 patients were cancelled. So we identified the cause of cancellation for the 220 patients and conducted a root cause analysis using, as you see on the diagram, using the fishbone diagram as high cancellation rate as the main problem. So we list the cause of cancellations and put them in 18 similar factors in one. So the commonest one was patient related and water time, and followed by lack of medication, especially ketamine was the commonest problem at that time. Therefore, the most important areas for improvement was preoperative patient optimization and operation theater time management. And this project was in accordance with national and facility strategic plan, surgical efficiency as a priority area. So the project was done on 11 surgical units and 6 operation tables. All elective surgeries in the time frame were included. These were the interventions chosen. The first intervention was establishment of preoperative anesthesia clinic for preoperative medical workup and optimization prior to admission. So we established a dedicated outpatient clinic for anesthesiologists to evaluate surgical patients before admission. So if their patients are unfit for surgery or for anesthesia, they will be optimized prior to admission. The second one was a centralized scheduling system where every unit, 11 surgical units as I mentioned, will send their schedules to the OR director office prior to posting on the OR dashboard. The third was support supervision. A task force was established by the OR leadership to assist, especially early morning, for the early initiation of the first case decision time. So this team will facilitate early. The fourth one was expansion of upstream units, post-anesthesia care units, especially where we were deficient with PICU tables. So there was some expansion. We had we have to make it 1.5 PICU table for one operation table. So we choose indicators, cancellation rate, average first case decision time, and surgical volume, and then follow serially. Data collection was conducted using a checklist prepared to assess the outcome and process measures. Real-time data was taken daily and with corrective measures daily. Then the data was presented using run chart. 10 data points were obtained at the end of the project and interpreted using run chart interpretation technique. So as I mentioned earlier, this study was conducted on 6 major operation tables and 11 surgical units. The units were general surgery, pediatrics, urology, neurosurgery, GI surgery, hepatobiliary, gynecologic, plastic, orthopedics, ANT, oral and maxillofacial surgery. During the study period, there were 3,293 elective cases scheduled and 2,812 elective surgeries performed, and 478 patients cancelled. So the cancellation rate was high cancellation rate was the cornerstone of this QI project. So cancellation rate decreased from 31.5 at prior to the implementation of this study to 10% at the end of this study, with a mean of 14.5%. The range chart exhibits strong special cause consistent with reducing cancellation rate after the intervention. Average first cancellation time prior to the intervention was around 9:30, and upon the implementation, it come to almost 9 a.m. and plateaued there. The surgical volume rises concomitantly with the decline in the RE cancellation rate. But first, when we started this baseline study, we found out that we have a lot of backlog, so we conducted 2 months weekend surgery. So in the first 2 months, the results were higher. So the first graph in the left upper quadrant was cancellation rate prior to the initiation of this project. It was for 3 months. As you see, it's almost 38 in the first month, and then 25 in the second month, and then 31 in the third month. And then after initiation of this project, as you see on the second graph on right upper quadrant, see cancellation rate going down from the baseline. You see the first 3 points are the baseline findings, and then it drops with the initiation of these boxes. You see are the interventions. So the interventions, most of the interventions were started within 3 months. So the graph, as you see, was declining. It reaches 12.5 on the third month, and then showed some fluctuations, but still steadily declining on the starting from the 6 months up to the 10 months. The third graph on the left lower quadrant was first cancellation time, which was higher prior to the initiation of this project, and then rapidly declined to 8:45, especially when there was tight supervision, and then showed some rebound, but plateaued there around 9 a.m. The total number of surgeries were higher in the first 2 months, as I mentioned, because of weekend surgeries, but then it was consistent throughout, between almost 400 surgeries monthly. So the discussion: elective surgery cancellations have a negative financial impact for many facilities and have low patient and family satisfaction. It can also cause dissatisfaction to staff as well. Implementation of this QI project is financially beneficial for all surgical units by decreasing cancellation rate and increasing OR efficiency. Majority of the costs of elective surgical cancellations were avoidable. Thus, efforts should be made to prevent the occurrence of unexpected cancellation. Quality improvement projects should be implemented to address both patient-related and hospital-related factors with careful planning. So limitation: in this QI project, there are some factors left unaddressed because of the cost of the intervention, and the interventions were nearly simultaneous, and so we cannot assess the effectiveness of single interventions. So as a conclusion, this quality improvement project is locally designed based on the gaps found in Jimma University Medical Center or efficiency finding. So every hospital needs to design quality improvement projects based on their context. Model for improvement using Tadesse cycle is an effective measure to reduce cancellation rate. It works for our hospital. This project was presented at Ethiopia National Quality Summit to promote to other hospitals. The implication of this project was support to supervision and central scheduling system was effective to enhance communication between staff to reduce cancellation and time management, especially such interventions which has low cost but high yield interventions are highly recommended in low resource settings. The institution should create a culture of eliminating waste, optimizing patient pathway, and efficient professions. As many quality improvement projects rebound after completion of this project, we should keep the track of the cancellation rate. Continuous monitoring and involvement of relevant stakeholders is crucial to ensure sustainability. So this is my acknowledgement. This is informal consent, and thank you. Thank you very much.